And the fellow presenter from cardiology will be Dr. Khalifah Aldawsari. Thank you.
Hi, everyone. My name is Khalifah Aldawsari. I'm a pediatric cardiology fellow at Colorado Children's Hospital. Thank you for having me today. Our case presentation is about single ventricle palliation and heterotaxy syndrome with a primary ciliary dyskinesia. Our patient was born at 37 weeks with a prenatal diagnosis of heterotaxy syndrome and complex congenital heart disease based on fetal ultrasound and MRI. Postnatally, he was confirmed to have right atrial isomerism and balanced AVSD and double outlet right ventricle with pulmonary atresia and an obstructive total anomalous pulmonary venous return, thus draining to right-sided atrium. Also found to have visceral situs ambiguous with a midline liver and left-sided stomach and absent spleen. Given the complexity of the congenital heart disease, single ventricle pathway was the only surgical option, which typically involves 3-stage surgeries. At the age of 3 days, the patient underwent stage 1 palliation, which consisted of PTT shunt that connects the right subclavian artery to the right pulmonary artery to provide more consistent source of pulmonary blood flow. In addition, had bilateral pulmonary artery reconstruction. Following the surgery, the patient remained intubated for 20 days due to persistent atelectasis of the right and left upper lobes, not responding to conventional respiratory treatment, and had bronchoscopy that was showing bilateral right-sided lung anatomy. However, no significant obstruction was seen. The evaluation of primary ciliary dyskinesia started around the age of 3 months. However, the initial sample of the nasal turbinate was not adequate to provide any information. Therefore, underwent a repeat test a week later that revealed abnormal ciliary ultrastructure with a partial outer dining arm deficiency. These findings were consistent with the diagnosis of PCP. Genetic testing revealed compound of heterozygous pathogenic variant in DNA H5. These 2 variants were associated with the diagnosis of PCD. The medical course between stage 1 and stage 2 palliation was remarkable for malrotation that was seen in upper GI study, and that the patient underwent G-tube placements with the LADS procedure. And despite being exclusively fed through the G-tube, had persistent emesis and underwent nascent fundoplication. Also had bilateral pulmonary artery plasty and PTT shunt upsizing at the age of 4 months, and had cardiac arrest event that was secondary to an aspiration requiring CPR and intubation at the age of 4 months. As part of the evaluation of stage 2 palliation, the patient underwent cardiac cath at the age of 8 months for hemodynamic evaluation and found to have elevated pulmonary vascular resistance and was started on sildenafil. And at the age of 12 months, underwent bidirectional glen and was extubated on the same day of surgery and discharged home within a week of the surgery. At the age of 2 years, the patient completed extracardiac Fontan. However, the course was complicated by elevated Fontan pressure and reduced cardiac output in the immediate postoperative period, for which underwent Fontan revision on day 2 post-op. Following the revision, required some oxygen and chest PT and positive airway pressure, and the total length of hospitalization was 18 days. Now the patient is almost 11 years old, doing well in homeschool, followed by multidisciplinary subspecialists, including our Fontan multidisciplinary clinic that includes cardiology, pulmonology, gastroenterology, immunology, infectious disease, and our special care clinic. The frequency of hospitalization has significantly decreased since stage 3 palliation. Our points for discussion includes what are the benefits of early genetic versus functional testing in single ventricle heterotaxy patients. Second, are single ventricle heterotaxy patient with primary ciliary dyskinesia candidate for a stage palliation of congenital heart disease? And third, how are primary ciliary dyskinesia patient with a single ventricle physiology best managed? Thank you.